Dear students, Haematology classes to continue. R.A.T.S in Pathology. As promised, I always take only the university questions for the students. A case history. A 3-year-old child presented with mild fever and breathlessness. On examination, cervical lymphadenopathy and mild splenomegaly were noticed. What is your diagnosis? The blood picture showed a hemoglobin of 8 grams per deciliter, an anemia. In fact, it is a moderately severe anemia. The total count is 1.2 lakhs per cubic millimeter. The platelet count is reduced 70,000 per cubic millimeter. So, what is your diagnosis? And the peripheral blood, let us see what we are seeing. The RBCs are more or less normal, but I'm finding some abnormal cells. They are much larger than the RBC. The nucleus is also large. There is a little bit of cytoplasm in some cells, whereas in others it is totally scanty. So your diagnosis is acute lymphoblastic leukemia. So these are the points of importance in it. Kindly follow the class. Acute lymphoblastic leukemias. Definition per se is common to the acute leukemias, which are malignant clonal disorders arising from the hematopoietic stem cells. They are characterized by proliferation of the poorly differentiated blast cells, which are the immature or rather the most immature form in the bone marrow. An important feature of all the acute leukemias is maturation arrest. Remember A for acute, maturation arrest is there. And in ALL, you find it involves the lymphoid series. What it is, we shall be seeing. Look at this one. There is a stem cell. It shows a myeloid differentiation. It shows a lymphoid differentiation. Differentiation means developing in that direction. So it is a lymphoid stem cell from which you can get a lymphoblast, which can again develop into either a B lymphocyte or a T lymphocyte or an NK cell, natural killer cell. So when it is at this level, it develops an acute lymphoblastic leukemia. The age. Whenever a case history is given or when you are going to see a patient, age is most important because it is a common disorder of children. It does not occur in adults. Maybe one can be in children of an older age, but definitely not in adults. The onset is acute or insidious. Insidious means without any pre-warning, etc., it develops. The duration is short because the cells are proliferating and then there will be a compromise in the respiration, in the heart function, etc. There is fatigue, persistent fever, and there can be a lymphadenopathy and hepatosplenomegaly. Extramedullary infiltration into the CNS, testes, and eyes can be seen. Look at this child. One thing, behind the smile, I can see an anemia, a sense of gloom. And obviously, there has been a chemotherapy and the child has lost its hair, which will again come back once the treatment is over. Coming to the causes, I would request you people to kindly go back to the causes we had mentioned in the acute leukemias in AML, etc. It can be genetic, it can be because of radiation injury or exposure, or sometimes it can be because of occupation, such as the radiologist, and in certain other cases, it can be because of chemotherapy itself. Viral infections are also prone to result in leukemias. So these are already given. I would like you people to kindly go back and refer. FAB classification. There is an FAB, which is French, American, and British. Classification for the myeloid leukemias, so also for the lymphoblastic leukemias. Here it is divided into L1, L2, and L3. Which is small? 1, 2, or 3. Obviously, 1 is small. So the cells are small, uniform, homogeneous. The nucleus is also smaller than the rest. NC ratio, that means nucleus is high when compared to the entire cell. There is no conspicuous nucleoli. Cytoplasm is scanty, no vacuoles, and prognosis relatively better than the other two types. L2, it is a mixture of small and large. We call it heterogeneous. And there is some amount of indentation. Indentation means a dip in the nucleus. NC ratio is lower. And the nucleoli can be 1 to 2 in number. Cytoplasm is slightly more than the small type. Vacuoles are not prominent, prognosis is bad. L3, the leukemia, is a counterpart of the Burkitt's lymphoma. We have already completed the class on Burkitt's lymphoma, and it is its counterpart. Uniformly large cells, homogeneous. And the nucleus is also large. And you find that the cytoplasm is a little more abundant, therefore the ratio becomes less. Nucleoli can be present, and the cytoplasm is abundant with vacuolation. The counterpart is Burkitt's, prognosis is worst. Common in Africa, and we had mentioned two types. It can be sporadic, it can be familial. Go back and read that one. This particular classification we shall by heart and write. Coming to the blood picture. In blood, always there are two components. One, there will be general features. For example, hemoglobin is reduced. It can be moderate. Later stages, it will become severely reduced. The RBCs are normocytic, normochromic. Look at this one. In the late stage, the patient can have as low as 3 grams. And obviously, there will be a cardiac failure. Platelets are reduced. And it can be moderate to severely reduced. So this is a general feature. Purposely and pertinently, I have not included the WBCs in this. There is another classification called the WHO classification, which I would like you people to write. Precursor B lymphocytic, lymphoblastic, precursor T lymphoblastic, and the Burkitt's lymphoma. There are the 3 types which you people will have to mention. Write both the classifications. And coming to the blood picture, this is what I said I did not mention. In this, I am finding 2 population of cells. This fellow is relatively smaller than this. Here the cytoplasm is more. Nucleoli are the faint areas. I am able to see some faint areas which are the nucleoli. Not very conspicuous in this. So a mixture of small and large cells. It is an L2 type of a lymphoblastic leukemia. The blasts are small and large, even the smallest large compared with the RBC. There is a increase in the nuclear cytoplasmic ratio. Nucleoli, it varies from inconspicuous to 1 or 2. Platelets are definitely reduced. So this is another picture of a lymphoblastic leukemia. In this one, I am finding that the blood is flooded with the blast cells. I need not do a differential count at all. Very easily, it is more than 90 to 95%. RBCs are normocytic. Later on, they can develop an iron deficiency or B12 deficiency. Platelets are markedly reduced. The total count, look at the range. It can be 20,000 up to 2 lakhs. And the description of the lymphoblast I had mentioned, I will not be repeating again. Go through. Bone marrow generally is not done for a leukemia because I'm finding the blood flooded with cells. We will do it whenever there is a response to treatment and we want to assess it. So we will be doing it. Or sometimes there won't be any blast cells in the peripheral blood. In such a case, we will have to do a bone marrow aspiration to confirm. Bone marrow whatsoever, it will be hypercellular. All the other cellular elements are suppressed. You find blast cells will be more than 25% in the WHO and more than 30% as per the FAB classification. Please remember this, you people will have to write it. It can be asked as an MCQ. If you write, you get a mark. But commonly we find that blast can be 50 to 90%. Look at the previous slide here. Very easily I can say it is 90%. A differential diagnosis will be sometimes there can be a reaction to viral infections. There is one condition called as leukemic phase of lymphoma. Lymphoma is one condition. There is a Hodgkin's, there is a non-Hodgkin's. But when the cells overflow and they spill over into the peripheral blood, it is called a leukemic phase of lymphoma. Sometimes metastatic tumors, small tumors such as tumor cells as seen in Ewing's can be present. So these are all differential diagnoses which people can mention. In fact, all this will come under the category of small round cell tumors. What are the investigations and treatment? First, you will have to do an immunophenotyping to find out whether it is a T cell or a B cell. Sometimes cytogenetic studies will be necessary. You find that there are more than 50 chromosomes due to hyperdiploidy. X-ray can show mediastinal widening because there can be a mediastinal infiltration, TALL. Sometimes there can be infiltration into parenchymal organs such as the testis. This has to follow up with biopsy after treatment. CSF, rarely you find that leukemic cells can be seen in the CSF also. So these are all the other investigations. Please remember, general blood investigations, then the blasts, the description, L1, L2, L3, the types, and then the other investigations. The treatment will be chemotherapy. There is a good response. It almost disappears. There is a condition called as maintenance chemotherapy, where they will try to maintain the low level of the cells. CNS, sometimes they can give a prophylactic irradiation. Of course, supportive treatment, nutritive treatment, platelets, and other cells can be infused. Biochemical parameters will have to be. So the types we have already seen, I will not be repeating it, but usually there will be a confusion between a myeloblast and a lymphoblast. For that only, we will have to do a cytochemistry of leukemias. These are all lymphoblasts, and when stained with PAS, periodic acid shift, I find that there are large blotches in the cytoplasm. We call it as block positivity. This will definitely be a question for you people, MCQ. Block positivity is classically seen in DASH, and it is supposed to be a lymphoblast. So in cytochemistry, we will be able to distinguish between a myeloblast and a lymphoblast. Fighting back. So obviously an important diagnosis. Once we make a correct diagnosis, nowadays you find that oncology, chemotherapy, they have all taken splendid steps and the recovery can be wonderful. And please remember, the typing is also important. Not only should we diagnose the lymphoblastic leukemia, but what type it is, because each type has got its own chemotherapeutic treatment. And this is the cytochemistry of leukemias. I have already given it to you people in the AML. Again, we will have to follow. The most important thing for me will be the periodic acid shift, which produces a block positivity. There is another type of leukemia called as a hairy cell leukemia, in which it will be positive for TRAP, tartrate resistant acid phosphatase. These things are regarding the lymphoblastic leukemias. Common sense is not a gift, it is a punishment, because you have to deal with everyone who doesn't have it. A wonderful saying. Always common sense is extremely important. Which means, why am I putting this quote? What do I derive out of this? This is a tabular column that is showing the lymphoblast and the myeloblast. There are the differences, you people are going to read it. I am not going to recite it again. But then this particular chart or table, I can use it for a question on myeloblastic leukemia. I can use it on a question on lymphoblastic leukemia, or sometimes in general acute leukemias, wherever it is. And a lot of these things, for example, a convoluted nucleus, 3 to 5 nucleoli are all classical of a myeloblast. R.A.T.S will be present. So, and what are the special strains which can be done? All are given in this. Kindly read this one. It is worth carrying. So also this. What are all the clinical differences? What occurs in children, what occurs in adolescents and adults? And there can be a lymphadenopathy, so on and so forth. So that brings us to one area. Patience is also a form of an action. I think we people should be patient. We shall wait because we have got R.A.T.S, chronic lymphocytic leukemia. This also is given over here. It is important. It can be given as a chart or as a slide. Definitely a university question or short note. Sometimes it is an essay. So definition, it is a neoplastic disorder with the production of mature B lymphocytes. Lymphoblastic is immature. Here it is mature. But then they are immunologically incompetent. The variants can be, mainly it is the B cells, but sometimes you can get a T cell variant of it. Incidence, they say mostly in the Western countries, but nowadays it is commonly seen in India as well. And the age is definitely beyond 50 years. Don't say it is a 25-year-old male and then call it a chronic lymphocytic leukemia. Highly unlikely. It is a disease of old age, and people say that you die with the disease rather than of the disease. I would like you to kindly mark 6 differences between you people and these. Somehow I like them. The students over here, they are innocent, they are smiling, they are happy, and they are all uniform. Look at the picture over here. I'm finding cells. So all the cells, if I see one region, I need not see anything else. They are more or less uniform. That is what I meant by this. Go back to this. So I find uniformity in the cells. So hemoglobin is mildly reduced, but later on it can become moderately reduced. RBCs are normocytic, normochromic. And a few patients can be having spherocytes. There can be an acquired spherocytosis, where Coombs test can be positive. Platelets are reduced. All the leukemias, platelets are reduced except CML. And serum bilirubin can be raised if it is going to be a hemolytic anemia. And there are some cells, as we make a smear, they become smudged or squashed. And I cannot make out what they are. They are called as smudge cells. So this is the general feature that we'll have to remember. As I told you, the age is 50 to 75 years. Patient definitely will be having an anemia. There will be lymph node enlargement. We should be extremely careful. Chronic lymphocytic leukemia will be having a lymph node enlargement. But otherwise, it is an incidental finding or an indolent, sweeping, rather a sleeping disease. Disturbance vandale. So this is the clinical picture that we people see. The age will be 50 to 75 years. Patient has got an anemia, mild or moderate. There will be a lymph node enlargement. The disease is incidental or indolent, a sleeping disease rather. Splenomegaly will be present, mild to moderate. There can be a mediastinal pressure because of the infiltration. And the spinal cord shows compression. Mild hemolytic anemia can be present in 10% of the cases, and they will be showing spherocytosis. And look at this peripheral picture. A lot of cells, they are increased in number. These are all small lymphocyte-like cells. There are some cells which are slightly larger. They are having a slightly greater amount of cytoplasm. They are the pro-lymphocytes. So 95% will be lymphocytes, about 3 to 5% will be pro-lymphocytes. A good number of smudge cells or basket cells can be seen. Platelets are reduced in number. Now, what are the complications in this one? There can be an autoimmune hemolytic anemia. Coombs test is positive. There can be a decreased levels of immunoglobulins. Thrombocytopenia, granulocytopenia can be present. And there can be a Richter's transformation. WBCs are increased in number. The count varies from 50,000 up to 2 lakhs. The cells will be resembling the mature small lymphocytes, uniform. Occasional pro-lymphocytes can be seen. A good number of smudged or the basket cells. Neutrophils are reduced, obviously. So this is a lymphoma for a differential diagnosis. The lymph node is being replaced by tumor. It is flooded with lymphoma cells or any other organ. And when it spills over into the peripheral blood, I can see this kind of a picture. This is called a leukemic phase of a lymphoma. But I find that the platelets are all normal. That will be the only difference that we can see. Otherwise, it might be difficult for us to make a diagnosis. Lymphoma spillover in a case of a lymphoma into the peripheral blood is a differential diagnosis. Left without right is equal to 0. Many students write only this. They write schoolgirl pattern and they expect an answer. That is why you are writing the left, omitting the right, we will give you 0. You should describe the peripheral blood. What are all the causes? What are all the other hematological findings? What is a Coombs test? What can be the clinical manifestations, etc. And finally, you can just add a feather to its cap by a schoolgirl pattern. Similarly, do not write just college girls in a case of chronic myeloid leukemia. I hope you people can describe the difference between these two, a college girl and a school girl, which means CML and CLL. I hope that you people can make a difference with us.